everyone. This is Morphology Amigo. I am a locum hematology consultant in the NHS. My interests are frontline hematological diagnostics and hematology content creation. With me in HaemBytes is Nihar Desai, a friend and colleague from Mumbai, and hemato-oncologist by trade, and also Anas Nasser, who is a biomedical scientist at Guy's and St. Thomas's NHS Trust. We welcome you to HaemBytes. Hope you enjoy. Let's start. Can I just ask, can everyone see the screen properly, please? The slides that I'm projecting.
Yeah.
Perfect.
Yes, sir.
Oh, okay, thank you. So let's start. So the objectives of this exercise is very simple. It's going to be looking at interesting cases, and these are real cases that I see and I keep tabs on, during the course of the last few weeks. There's going to be quick discussion points about each case, some pitfalls of interpretation, which are relevant for the exam because the exam is all about giving you a stem, you latching onto a narrative, and then hopefully trying to come up with the answer that the college wants. And some FRC path stress relief tips. It is going to be a daunting undertaking for colleagues who are either taking part 1 or part 2, part 2 being slightly more daunting than part 1. And in the end, we'll finish off by just having some hematology queries. If you have any other questions which are related, unrelated to your training, or just some interesting things or interesting cases that you have looked at, by all means, we can discuss. Then I would like a collaborative approach with everyone taking it in turns to give me their thoughts, and then we'll hopefully distill it into a sensible narrative, which is good for your everyday work and good for your exam. Right, let's start. Okay, so I just thought we start off with a very simple theme. So this 80-year-old woman has been referred to you and has come to your clinic with painful hands. Now, I want you to have a think about the first line that I've written, have a look at the numbers, and then one by one, please start giving me your thoughts in terms of how you would approach this. Now, because this is a little bit exam-centric, I want you to think from simple things to less simple things, and that's exactly what the exam is testing as well. So please, fire away.
Well, the first thing I note, there's thrombocytosis, platelets 1,400,000 plus.
Yep, that is absolutely correct. It's a quite a stark thrombocytosis, isn't it? Now, any other comment from anyone else? So please look at the stem. You see, in the exam, the stem sometimes gives the question away. It'll probably lessen a lot of your adrenaline and your stress responses. So is there anything you can latch on from the stem? Anyone else? Please, everyone contribute. It's a collaborative learning exercise.
The painful hands?
Yeah, what could that be?
Well, in the context of thrombocytosis?
Yeah.
Raynaud's?
Okay, anyone else?
Microthrombi type picture.
Exactly. Microvascular symptoms. So immediately you look at the stem, just kind of thinking about something. You've got very few minutes to kind of set your mind in one direction. And that's the issue with the exam. In the exam, time is passing so quickly that you will either latch on to something and hopefully that's the correct train of thought, or you might get sidetracked, in which case you might just sacrifice a little bit more of your time and then you might find that you're sacrificing the next question. So absolutely correct. You've got an 80-year-old who's got painful hands now. Well, you could have microvascular symptoms, as our colleague said, there could be Raynaud's, there could be arthritis, there could be something. But the extreme thrombocytosis is telling you something. Now, if you have a look at the full blood count, it's not just thrombocytosis. You've got a normal hemoglobin, you've got a normal MCV. So it's clearly not iron deficiency either. Obviously, you need to still look at a blood film, but even on first glance, you're like, it's unlikely this is iron deficiency. And if you go down, you start to get a bit of basophilia, a little, and you start thinking, could this be something on the myeloprolif line? But that's something you have to just park at the back of your mind when you start this expedition, because common things are common first. So think reactive. You need to do your ESR, LDH, CRPs. You need to get a good history. Obviously, do your serum ferritin and transferrin, and then have a look at the blood film. And then you need to decide what happens next. Now, in this case, what happened was that this lady presented just on the background of such a thrombocytosis. And we all know that when we send JAK2s, even an urgent JAK2 in the United Kingdom is not going to be less than 7 days. So you have someone who you need to work up very quickly. So in this particular case, what I did was I was like, I don't have the luxury of a JAK2. I just can do some simple things and I'll look at a blood film. And this is what the blood film showed. Well, we'll just come to it in a bit. But if you see all the reactive causes, you have a normal serum ferritin, you've got normal ESR, the CRP was normal. And then you start thinking, okay, let's see where we get to. So now this was the blood film. You can clearly, is the blood film projecting okay? Can you guys see it properly?
Yeah.
Perfect. Now I'll just, hopefully you can see my mouse. Just look at the size of these platelets. Just look at this size, look at this size, look at this size. These are chunky platelets and they're all over the place. And this is just one shot. There was extreme thrombocytosis. I've even seen a basophil or two. Clearly, you can see this is not a hemoglobinopathy. This is not iron deficiency. Looking down the blood film, this is most likely a case of myeloproliferative disorder. And if you roll back the clock to times pre-MPD molecular screening, this is how these things used to be picked up, plus minus a bone marrow. At that point, obviously, the bone marrow was there. But can anyone tell me if, let's say, we didn't have the luxury of JAK2, CALR, and MIPL, is there any other way to prove that on bone marrow that this is ET? Anyone?
You've got the classic megakaryocyte changes, the sort of Staghorn megakaryocytes, and excessive numbers, clustering.
That's correct. That's the magic word, my friend. Megakaryocyte excess, staghorns, clustering. So if I had to do a bone marrow on the aspirate, I would not find much. It is the trephine. But even on the trephine, considering decalking of the bone and everything, you're not going to be looking down, like you do a bone marrow on Monday and you can see the trephine on Wednesday. It's going to take some time. So in this case, I took it to MDT very quickly on email and I said, listen, I don't have the luxury. Looking down the blood film, this most likely is ET. So we'll just start cytoreduction based on good principles. Everyone agreed. All the reactive causes were negative. Gave her alternating doses of 1 gram and 500 milligrams plus aspirin. And now, within 6 weeks, she's got a platelet count of 420. And I've reduced the hydroxycarbamide dose down to, I think, 500 milligrams Monday to Friday with aspirin. And, her microvascular symptoms have gone. She was a little bit catabolic. If I remember, I'm just losing weight. I don't feel right. And now she is feeling much better. Clear, and there are no side effects from the hydroxycarbamide, and everything is good. So what this case illustrates is the importance of first-line investigations/diagnostics, the ability for you to get to a certain answer very quickly based on the best thought patterns, and then having the evidence to back up your convictions, going through an MDT process with your colleagues, ratifying some hydroxycarbamide, and then going forward with patient management.